Welcome back, friends. We had seen how to take history of an infertile couple, especially the examination of the female we have seen in details. Now, tests for factors. Now let's come to this important ovulatory factor. What are the tests for ovulation? Basal body temperature, that is BBT. We all know that whenever there is ovulation, there is release of ovum, formation of corpus luteum that secretes progesterone. So the temperature, if taken in a woman once she gets up from the bed before she eats, so if we ask her to take her temperature in Fahrenheit and she marks it on a graph, there is a fall at the time of ovulation by half a degree Fahrenheit, and once ovulation is there and release of progesterone is there, then there is slight rise in the temperature in post-ovulatory phase. So this biphasic pattern is indication of ovulation. It's not very practical test to be done. We have better tests practically done, but from exam point of view, these tests are important. Then cervical mucus test, Hormone test, MCQ, to be done in between day 12 to day 14, means pre-ovulatory, around ovulation. Typical appearance of cervical mucus, spin Burkite, that the thread formation means if you pick up cervical mucus and pull, there would be thread formation which may be around 10 centimeters. Its stretchability is increased. So we call it as spin Burkite positive. If you see the cervical mucus under microscope, there would be ferning pattern. And this ferning is seen due to the influence of estrogen, there is presence of sodium chloride in the mucus, and that gives this fern appearance. These all signs are pre-ovulatory. Ferning is seen because of effect of estrogen. Spin Burkite is also because of estrogen, around 12 to 14 weeks. Now what happens once there is ovulation and there is corpus luteum formation, progesterone comes in role and the secretions go on increasing gradually. So now the cervical mucus will change from thin, watery, sticky to thick. It would form a plug. It will not have that thready consistency. It will break, and this is called as tack. It is seen from day 21 to 23. The mucus would become thick, breaks on tension, and ferning would be absent. So these changes would tell us that there is ovulation taking place in that particular female. Spin Burkite, Hormone test, tack, 3 MCQs in one test. Other test for ovulation, endometrial biopsy. Histopathologically, we all know that the changes which take place in proliferative as well as in secretory phase of the menstrual cycle, they are very specific. And from the endometrial examination, histopathologically done, whatever changes we see, the proliferation in the glands or the subvacuole formation or secretion collection, all these changes can tell us that which day of menstrual cycle that patient is in. Am I very clear? That looking at the histopathology of the endometrium, which we have obtained on endometrial curettage or endometrial biopsy, if we do the examination, by reading or by seeing the changes, we can guess, or the report can tell us which day of menstrual cycle that woman is in. Either she is only in proliferative phase or in secretory phase. Not just that, but which day, 21, 23, 25, this specific the changes are. Usually this biopsy is done premenstrually, just 1 or 2 days before menses. If there is secretory changes seen on the biopsy, it directly confirms that ovulation has taken place. She has progesterone. First sign of ovulation, MCQ. Parabasal vacuolation in the endometrial glands is the first sign of ovulation, presence of progesterone. In luteal phase defect, how do we diagnose that it is luteal phase defect? In luteal phase defect, her day would be, for example, day 23, but the changes which are seen on histopathology would have 2 days out of phase. Means the changes would be either of 20th day or 21st day. So the changes and the menstrual day are not incongruent with each other. Day is ahead, changes are lagging behind. If there is lag of 2 days, if the changes are 2 days out of phase, we label it as a luteal phase defect. This is because of deficient progesterone in that particular patient. Added advantage of endometrial biopsy. It tells us about ovulation, yes, but added advantages are it also rules out tuberculosis. Tubercles present in the superficial layer may get shed off and PCR will come positive. Best test which is practically done are not any of these, but follicular monitoring. On ultrasound, we go on observing the follicle. It gets selected, then it gradually goes in size. Usually the sonography is done from 10th day to 16th day. And suddenly on 14th or 15th or 13th, the growing follicle vanishes. It disappears. We cannot see that follicle anymore on ultrasound. And because of ovulation, there is some free fluid seen in the pouch of Douglas. So these are the signs of ovulation on ultrasound. Follicle growing around 20 millimeter to 22 millimeter suddenly disappears, and there is presence of fluid in the pouch of Douglas. These are the signs which tell us that ovulation has taken place. There can also be evidence of corpus luteum which can be detected. Serum progesterone levels, another test. Day 8, the levels are very low, less than 1 nanogram per ml. Day 21, the levels would be more than 6.5 nanogram per ml. So you know that's the period when progesterone has maximum concentration. Vaginal cytology, if navicular cells are present, there is ovulation. We can also do hormonal studies to find out about ovulation, and the hormones are progesterone levels, usually done around 21-22 day, mid-luteal, LH surge, FSH levels, thyroid hormone tests, or prolactin levels to rule out hypothyroidism and hyperprolactinemia. So these are important hormones which we do in infertile female patient. Now coming to tubal patency test. Tubal factor, another important factor. So which test will tell us that the tubes are patent, they are open? This test is done always pre-ovulatory. Please remember this point, that these tests wherever, or any test wherever the patient, reproductive age group patient, is getting exposed to X-rays, all those tests are always done pre-ovulatory, because we don't want that ovum to get exposed to radiation, or in case if she conceives, then the early embryo to get exposed to the radiation. So please remember this rule of 10, that all the radiological tests in the female done in reproductive age group, means female in reproductive age group, if we are doing any radiological test, it has to be done before day 10th of her menses, pre-ovulatory phase. Patency of tubes and physiological ciliary action we want to see in the tubes. First common test is hysterosalpingography. It's the first test of tubal patency. In that, what we do is radio-opaque dye is injected into the uterine cavity. The cannula is attached at the cervical end. The dye goes in the uterine cavity, then to the fallopian tubes and comes out. X-rays are taken, first, second, third. First it delineates the cavity, then the tubes, and then we will see the spillage, both the sides, or if there is block, no spillage would be seen. Tubercular salpingitis is very common. How we detect it? There can be bilateral cornual block. There can be extraposition of the dye. Red pipe rigidity can be seen. Beading, calcification. Every word is important here. Tubercular salpingitis on HSG, bilateral cornual block or extraposition of the dye. Lead pipe rigidity, tubes are like pipe, no wavy pattern, it's lost. Beading, calcification. These are the changes specific of tubercular salpingitis. But please mind well what I am going to talk right now. In a patient in whom you are suspecting tuberculosis, hysterosalpingography is contraindicated. Even though we have learned the changes which take place in tuberculosis, but if you clinically suspect that this patient, infertile or whatsoever complaint she has come with, if there is any suspicion that she may have tuberculosis, you are not supposed to do any invasive test including hysterosalpingography. Because you do the test, the fluid comes out and that's going to spread the disease. So it is contraindicated. Confirm, rule out that she doesn't have tuberculosis. If she has, give AKT. If she doesn't have, then proceed with the test. Most common site of genital tuberculosis is fallopian tubes, 90%. Uterus in 70%. In TB infertility, the infertility in tuberculosis is because of block and loss of tubal function both. So depending on what options available, but block is the commonest one. On USG, there can be cogwheel appearance because of incomplete septation in the tubal wall. Other tests of patency: laparoscopic chromoperturbation. This is done commonly and it is investigation of choice for tubal patency test. Putting a scope inside patient's abdomen that gives us overall view, how the uterus looks, how are the tubes, what is the peritoneal environment, how are the ovaries, are there any peritubal adhesions, everything you can see, which cannot be seen on hysterosalpingography. Then from the cervical end, you can put in methylene blue dye, and once you inject that dye, it goes, occupies the uterine cavity, comes out to the fallopian tubes, and when the scope is in, you can see blue color dye coming out through the femoral end. If it comes out on both the sides, both the tubes are patent. So this is investigation of choice or gold standard for tubal patency test, called as laparoscopic chromoperturbation. It gives us additional information about peritubal adhesions and endometriosis, and at the same time, if there are any pathologies found, we can treat them as well. So it is diagnostic as well as therapeutic. We can go for fulguration of endometriotic patches, or if there are some adhesions, we can do adhesiolysis at the same sitting under anesthesia. There are other tests, but these are obsolete now, like insufflation test, Rubin's test, where CO2 was pushed inside the cavity and then it was heard. Again, sonohysterosalpingography, it's also called as cyan test, in which 200 ml of saline is injected either via Foley's catheter, and once this fluid is moving in, at the same time you are doing ultrasound and you are seeing the movement, and if there are any lesions inside the cavity, they can be picked up very nicely. Falloposcopy, in which you put a scope and a cannula inserted through the femoral end, and which gives you the information about inside of the fallopian tube. There also can be salpingoscopy, which studies the mucosa. So falloposcope goes through interstitial end. Salpingoscope also helps in studying the mucosa of the fallopian tube. So these are the tests which gives us additional information. But commonly done test, practically HSG, but investigation of choice is laparoscopic chromoperturbation. What are the contraindications for these tests? They are never to be done during menses, because you know the theories of endometriosis. If during menses you push this dye, endometrium will be carried inside the peritoneal cavity. There would be deposits, and this will lead to endometriosis. They are never to be done post-ovulatory or just before menses. Never to be done immediately after curettage. In cases where acute salpingitis or any kind of infection suspected, never go for it. Tuberculosis, strong contraindication. If there is even lower genital tract infection, don't go for these tests. Now remember this syndrome from your exam point of view, Cartagner's syndrome. This is seen in both. There can be primary ciliary dyskinesia, immotile ciliary syndrome, means whatever the functional ability of the cilia of the fallopian tube is lost, autosomal recessive genetic disorder, and there is decreased motility seen in sperms in males, and in females decreased motility of the cilia of the fallopian tube. Now coming to cervical factor, where we are actually seeing whether the cervical mucus is present, whether it is congruent with the stage of the ovulation, and what is the interaction between the sperms and the cervical mucus. So these tests are most commonly done post-coital test. It's also called as Sims or Hooner's test. How is it done? Around the ovulation time, means we are doing ultrasound monitoring of the follicle. When we know that the follicle is of 20 millimeter size or around, the ovulation is likely. At the time, we ask the couple to have coitus. maybe early morning, and then we ask them to come to the clinic within 2 hours. Once she comes in dorsal position, we expose the cervix and to try to take out the mucus from the cervical canal or the posterior fornix. So when we take out the mucus, we see that the thread formation capacity, spin Barkite. When we are pulling it out, if the thread is formed, she is in pre-ovulatory good estrogenic condition, likely to ovulate very early. And then from the posterior fornix, whatever sample we have taken out from the cervical mucus, we see that how many sperms are seen. If 10 to 50 motile sperms per high power filled, we are happy. That means sperm deposition is proper. But if less than 10 per high power filled sperms are seen in the cervical mucus, then the deposition is not proper. Then at the same time, we can see what is the movement of the sperms in that particular cervical mucus. If it is forward progressive, we are very happy. But if it is shaky and rotatory, then it suggests that we should evaluate that couple for anti-sperm antibodies. So this particular test gives us information about ovulation as well as sperm penetration and also suggests whether the sperm antibodies are present or not. Other test, Miller-Kurzorg. Ovulation mucus is taken. It is placed on a slide. Half of the slide has cervical mucus and on the other half husband's semen is taken and placed, and the reaction is seen in the interface. If the sperm can penetrate cervical mucus more than 3 cm in half an hour, the results are good. But if the penetration is less than 3 cm in 30 minutes, then the penetration is abnormal and there can be presence of anti-sperm antibodies or there is some problem with the sperm motility. Again, other test, that is semen cervical mucus contact test. Equal quantity of semen and mucus are mixed. Presence of antibodies impart jerky, shaky or rotatory movements to more than 25% of the sperms in 30 minutes. If it is not there, it is normal. You can again cross check or control can be used where a donor semen can be mixed with the cervical mucus. If the donor semen shows good sperm motility, that means naturally in husband semen the antibodies or there is reaction between husband semen and wife's cervical mucus. Now coming to management of the female factors. If there are infections, we are supposed to treat them. Tuberculosis with AKT, PID with appropriate antibiotics. If there are presence of tubal factors, then the options are either tubal microsurgery, if there is block, tuboplasty or fimbrioplasty. If there are adhesions, then either laparoscopic tubal adhesions, tubal adhesiolysis, because open surgery will lead to again post-operative adhesion formation. So laparoscopic adhesiolysis. We can also do balloon tuboplasty and cannulation, which is done hysteroscopically. Tubal cannulation can also be done either laparoscopically or hysteroscopically. If the block or the damage of the tube is irreversible, cannot be repaired, then the option is IVF-ET, that is in vitro fertilization with embryo transfer in the uterine cavity, or gift can be used, that is gamete intrafallopian transfer. IVF-ET is the best option in such patients. Treatment for uterine causes. In case of Asherman's, there are intrauterine adhesions, so we are supposed to do adhesiolysis, either hysteroscopic. Then we can also start the patient on antibiotics or estrogen supplements, and we can put one IUD, that is intrauterine device, maybe copper device or any IUCD for a while till the adhesiolysis wound heals, so that the cavity doesn't come in contact, both the walls, they don't come in contact with each other, and healing takes place again without formation of adhesions again. So Asherman's, septate and bicornuate uterus, we can do metroplasty. For adenomyosis, we can do surgery or medical management. Fibroids, we can do myomectomy. Dyspareunia, correction of retrovirgin. Now in case of cervical factors, we can make sure that whether anti-sperm antibodies they exist in that couple. We can ask them to use barrier contraceptives for 3 months. Then we expect later the antibody response would be less. Or we can advise intrauterine insemination. In this, we monitor the ovulation on ultrasound. When the patient is likely to ovulate, once the follicular size is 20 mm, we give her HCG and then we call her after 36 hours. In that period, around that period, we collect husband's semen, wash it, remove all the debris, and all the good quality motile sperms are injected inside the uterine cavity with the help of a small catheter. Around 0.5 cc's are injected, and that is called as intrauterine insemination. It gives good results. For the peritoneal causes like endometriosis, we can either go for medical management or conservative surgeries like fulguration of endometriotic deposits. And usually such patients show good results later. Ovarian factors, very common factor, and we said it's a treatable. So PCOD, we can either go for OC pills for 3 months, metformin, weight reduction, diet, stress management, and then we can start induction of ovulation along with clomiphene citrate or FSH and LH. Luteal phase defect, we should give progesterone supplements. These are, as we agree, that they are very common, very easily diagnosed, treatable. But there are some types, like suppose we have patient with anovulation where FSH levels are very high, elevated. That means there is no ovulation taking place and FSH is very high. That tells us that there is ovarian resistance. Ovaries are not ovulating. That's why pituitary is continuously sending FSH. FSH levels high, estrogen levels either low, the ovaries are resistant or failed. In such cases, we have to calculate ovarian reserve of that particular patient, and we cannot waste time doing IUI or doing other modes of treatment. We should directly take that patient for IVF. Chronic anovulation with normal FSH, normal prolactin, we should start induction as early as possible with drugs like clomiphene citrate. It's a very commonly used drug. It blocks the estrogen receptors and thus causes more stimulation of GnRH, thus leading to pituitary secretion of gonadotrophins and thus selection of follicle, and there would be 2 or 3 follicles getting selected. Ovulation is possible in almost 80% of the patients on clomiphene citrate. Success rate of pregnancies is around 40%. In ovulatory women, it increases the GnRH pulse frequency, and in anovulatory, like in PCO, it increases the GnRH frequency and it increases the pulse amplitude. More amount of GnRH is getting secreted. The dose is around 50 to 100 mg daily from day 2 to day 5 of menses. Ovulation is expected around, it occurs 5 to 7 days after the last day of the therapy, means around day 12 or 13. If ovulation doesn't occur, then increase the dose in next cycle. We can go up to 250 mg per day for 5 days, but FDA approved dose is 100 mg per day. Side effects, it's usually well tolerated, but as it's an anti-estrogen, sometimes hot flushes, mood swings, headache, breast tenderness, pelvic pain, nausea, visual light sensitivity, blurred vision, scotomas. But all these changes are reversible, fortunately, and as soon as you stop the treatment, they will vanish. Complications, because there is multiple ovulation, chances of multiple pregnancy high, usually associated with LPD, that is luteal phase defect, so spontaneous abortions quite common. It may sometimes land your patient in ovarian hyperstimulation syndrome. No causal relationship between ovulation induction drugs and ovarian or breast cancer is yet established, even though we say more ovulation, more ovarian cancer. But still, there is no evidence of teratogenicity found. Biggest side effect or a condition, that is OHSS. It's a complication of ovulation induction either with CC or HMG or GnRH. Usually seen in young and lean patient, resistant PCOS. What happens is there is multiple follicle formation. Maybe 10-20 on this side, 10-20 on another side. It increases vascular permeability. Fluid shifts from intravascular compartment to extravascular compartment. Increase plasma viscosity. Increases clotting, there is depletion of sodium and albumin, and there is accumulation of fluid in the third place, that is ascites, or there can be hydrothorax. But because of this, what happens is there is hypercoagulation state and danger of vascular thrombosis is very high. So in such patients, we need to admit them immediately, correct the hypovolemia, maintain the intravascular fluid. The compartment should have enough fluid. That is how we can maintain renal and liver functions. We can also give prophylactic heparin in such patients if we are afraid of vascular thrombosis. Ascitic tapping is to be done when the ascites is tense. Other drugs used are HMG, GnRH in case of hyperprolactinemia, bromocriptine and cabergoline, corticosteroids in congenital adrenal hyperplasia, tamoxifen is very rarely given, metformin and letrozole in case of hyperinsulinemia and insulin resistance. So this finishes most of the part of female infertility. Let's stop here, and in next session we'll see male infertility. Thank you.